So thank you very much. It's a great honor. I'd like to join my voice to the previous speaker to thank Normand and Jonathan for this invitation and this great meeting. Thank you very much. I'd like to thank the sponsor too, because I was told the price of the room, and I felt that this was a great contribution. Actually, I'm heading back to Quebec City tomorrow. If someone is interested to rent my room, I'm going to give you a fair price, but I'm going to make some money out of it, right? So those are my disclosure. If you think about that, 15 years ago, we didn't have any to show. So which I think illustrate that as a pathologist, we're now part of some of this discussion. And I think it's great. And thank you very much again for making us part of these committee. I think we have something to bring, and this realm of biomarker and everything. I think we have a very important role to play as we're being at the interface of the tissue and the clinical. All right, I just want to take a minute to acknowledge the contribution of this project that I will be presenting in the next 10 minutes. I think I had the chance to meet Logan Walsh. I don't recall exactly how it happened, but that was probably one of the best things that happened to me in the last few years. Logan is an incredible scientist, but he's also a great person. So, and he was really the driving force behind this project. He's not here today, couldn't make it, so I'm the one presenting. But I think it was a great collaborative effort, including Jonathan, who's part of everything, right? Is he nice with the pathologist too? So he's perfect, right? He's the perfection. And also Pierre for contributing. And I'm not going to spend too much time on that given the audience, but you know that we're lagging behind when we compare with the most common, the four most frequent cancer. And I think the idea is to try to bring this survival curve up. We've seen progress over the last decade. I remember when I completed my fellow 10 years ago, it was 17%. Now it's 22%, but I think there's some work to do to bring this up. And this is from a snapshot of the situation a few years ago in the province here that shows that as it was shown also from the IASLC database, that basically most of the patients diagnosed with lung cancer have advanced disease, and only 30% or about 30% have a resectable disease. And we're doing this lung cancer screening program right now in Quebec, and this is going to be discussed by Nicole Ezar today and tomorrow. But basically, I think one of the ideas is to try to reverse this trend. And this is recent data coming from this lung cancer program here in the province, showing that we're actually diagnosing most of the patient in early stage with early stage disease. And I think this is really looking good. I know it's a small number, but I think this is pretty much aligned with the NLST and the Nelson studies. So we're anticipating an increased number of patients that will actually need surgery. And keeping in mind that for most of these patients, they're actually cured. And I know we will be discussing a lot about neoadjuvant treatment, adjuvant treatment. But for a resectable disease, stage 1 or stage 2, it's about 30% of the patient that will relapse. So which means that it's essential to know how can we identify the patient that are likely to relapse, and how can we identify the patient that are not likely to relapse and that don't necessarily need treatment. And that brings me to introduce this project that we did, and that was led by Marc Sorin, PhD candidate with Logan, and that we published recently in Nature. And that's basically trying to use a tumor microenvironment to predict relapse in these patients. And this is something that we see, Pierre and I, on a daily basis. This is adenocarcinoma, but this one is what we call a cold tumor. You don't see a lot of inflammation. It's mostly stromal cells and tumor cells, and this is forming glands, so SNR predominant adenocarcinoma. And this is also a SNR predominant adenocarcinoma, but this one is full of lymphocytes, right? So I think it makes sense to think that, you know, immune system is important. Immune system might be involved in driving the behavior of these tumor cells. So at my institution, I had the chance to come after this pneumologist, Dr. Michel Laviolette, who actually initiated a biobank 25 years ago and understood that it was really important to have access to human tissues to actually do translational medicine. And today, I think it makes sense. And we see all these clinical trials collecting the specimen to try to develop predicting biomarker, diagnostic biomarker. But we have now the chance at the ICPQ to have more than 5,000 patients from whom we have a surgical specimen, frozen tissue for molecular studies, but also blood and a lot of stuff actually with a very comprehensive set of clinical data as well. So we started from that 10 years ago when I came back and started my lab to build these small TMAs. So basically on a single slide, we were able to put 85% tumor from 84 actually patient on a single slide. And that was relevant at that time because we were trying to screen for these new predictive biomarker, EGFR, and these new ALK-ROS and everything, right? But also it was useful when we were trying to see if we could actually predict some of the clinical evolution using these small slide, because if we talk about phenotyping a single tumor with 45 antibodies, then it means that it's about $2,000-3,000 for a single slide. So when you can work with these small TMAs, that becomes extremely interesting. And this is actually from what we started from about 600 patients. And then after removing some of these patients that were not eligible, we ended up with about 400 tumor from 400 patients. And then we also had access through Pierre and Jonathan to an additional 60 patients from McGill. And that basically, we use CyTOF in Logan's lab to basically stain with about 36 marker that would define the microenvironment, immune marker, but also activation marker. And I think where Logan's really nailed it is he developed this algorithm that was very reliable to segment the cells. So if you think about putting a lot of antibodies with signal together, it's really important that you're able to capture every single cells and not getting all this noise because of the many antibodies that you're using. And I think he came up with this very strong way to come up with a very detailed and comprehensive description of the population of cells. And that's basically how we defined the tumor microenvironment. So you can see that we basically characterize all the typical immune cells that we have, but also added also some activation marker, proliferative index, PD-1, PD-L1, etc., to have not only a view of the number of cells, but also if they are activated or not, if they are dividing. And I'm going to try to keep this simple. And I remember first time that Logan were sending me some of the figure, it would take me 30 minutes just to digest the figure and make sure that I understood everything. So I tried to keep that simple and to be able to come up with the end message and the most important results to my eyes. So basically what you can see here is we look at the composition of the tumor microenvironment, and we looked at that in terms of clinical pathological data. So you can see that I had some influence here where we wanted to look at the architecture pattern of these adenocarcinoma. But the message here is really that I'm not sure where I'm supposed to. But basically, we wanted to show here that in some of these clinical data, such as survival, that had a prognosis impact, we could see a significant difference in the composition of immune cells. And this is just to illustrate, like in this one, that a good survival was associated with a high prevalence of B cells, CD20 positive cells. And we also found the same thing between the patterns. So basically, the overall message from that we could see in lung adenocarcinoma significant difference in the composition of the tumor microenvironment. But apart from having a number of cells, I think everyone working in immunology know that the interaction of the cells is probably more important than the composition of the cells. So basically, if you have a high number of CD8 cells, it's good. They're probably these cells are probably likely to kill tumor cells. But if they're surrounded by immunosuppressive cells, at the end, it equals 0, right? So we also develop a way to look at the neighborhood cells. So looking not only at a single population of cells, but at several populations of cells at the same time, and see if we could look at the neighborhood and see if we could see association with, again, a prognosis. And again, in this one, I'm showing 10 neighborhoods that Logan developed, but he actually tested several more than that. But we saw that some of these neighborhoods were strongly associated with good survival. Sorry, 10 minutes. So here, I think, starting from that, we said, can we use that? We see strong association with outcomes. Can we test that and see if we can predict the relapse of these patients that underwent lung cancer resection? So we took the stage 1 lung cancer, and then with the idea of looking if the frequency of the cells or the interaction and the organization of these cells would have an impact and would allow us to predict which patient were likely to relapse. And I'm not going to go in details to that, but I just can tell you that using AI and deep learning, we were able to show that you can actually pick up some of the signal in the architectural organization of the cells and being able to predict with a very high accuracy which patient were likely to relapse. And you know, I was actually, I would not say surprised, but I was impressed by the performance of that. But when we validated that on a totally independent court, we were able to reach exactly the same level of significance, which was, to my eyes, really impressive. So keeping in mind that one of the objective would be to implement that in a clinical setting, we tried to narrow that down to a very small number of markers, the one that had the more impact on predicting the relapse. So you can see the 6 markers that allowed us, again, to reach an accuracy of about 93%. So if you think about that and you have a patient undergoing lung cancer resection, and then you can use this 6 marker to predict which patients are likely to relapse, which one are not likely to relapse, I think I can see that as a very efficient way, you know, to implement, keeping in mind that, yes, we're planning to give adjuvant treatment, or we need to monitor this patient, or we need to adapt the follow-up of this patient. And I've been working with ctDNA, and Natasha presented about that this morning. My feeling about ctDNA right now in early stage cancer is we're not there yet. We're missing sensitivity in a lot of these patients. And we've been working with these big commercial assays that are sold for $2,000, $3,000 for single tests. And I don't think for early stage cancer, whereas in this case, thinking about 93% of performance is something that I've, you know, rarely seen in medicine, right? So what is next? I think we need to validate the 6 antibodies in a more traditional immunohistochemistry approach. You know, CyTOF is nice, it's cool, but it's a very complicated technology. So I think that's one of the next steps that Logan is planning to do. Can we reproduce this performance using a preoperative tissue biopsy? We've been working with 1 millimeter square core. And I think this is very similar with the size of the tissue biopsy that we're using, but we need to validate that. What is the correlation of the microenvironment between several areas of the same tumor? So we've shown that between two cores, that's about 91% of correlation, which is very high, but we need to really confirm that. And then what is the impact of tumor microenvironment in squamous cell carcinoma? We know that those are two different beasts. Is the tumor microenvironment really as important as an adenocarcinoma? We don't know that yet. So this week, we just completed another TMA in the lab, which we will use again to validate and see if we can reproduce again this result. And then I think we have a long road ahead, but a very promising road to be able to really streamline the management of these patients with early stage cancer. So thank you very much for your attention.